Anxiety disorder. Anxiety is a natural response to stress. It is a subjective experience that includes feelings of apprehensions, uneasiness, and certainty. Types of anxiety level. Anxiety level has four types: mild, moderate, severe, panic attack. Mild. Mild level of anxiety is it occurs due to tension of everyday life. This type of anxiety may be motivating and enhances high perceptions. Moderate. It focuses on immediate concern, it narrows the perceptions. Severe. Patient is feeling that something bad is about to happen. They need direction of focus. Panic attack. Panic attack means sudden onset of feeling with the intense apprehension, tremor, and disorganized personality. They have inability to focus. Signs and symptoms of anxiety: restlessness, inability to focus, sleep problems, physical discomfort. Panic attack symptoms are choking, chest pain, dizziness, blurred vision, feeling of anxiety. Management of anxiety: provide calm and quiet environment. Encourage the client to verbalize the feeling. Encourage problem solving. Attend to patient's physical symptoms. Assure the patient that getting anxiety is a normal process. Administer anti-anxiety drugs. Anti-anxiety drugs are which actions it depress CNS and produce relaxation and depress anxiety. Benzodiazepam, diazepam, midazolam, lorazepam. Anti-anxiety drugs in daytime sedation, dizziness. What are the signs and symptoms of anti-anxiety drugs? Dizziness, headache, blurred vision, hypotension, amnesia. Antidote of the benzodiazepams is flumazenil. Contraindication: ankle closure glaucoma. Post traumatic stress disorder. After experiencing a psychological traumatic event, the individual is prone to re experience the event under recurrent and intrusive dreams or flashback. Causes are natural disaster, murder, and accident, rape, terrorist attack, violence, physical, emotional, or sexual abuse. Symptoms are detachment, depression, anxiety, sleep depressiveness, nightmare, poor concentration, avoidance of the activity. Management: be non judgmental and supportive. Assure the client that their feelings and behavior are normal. Encourage the client to express the feeling. Assess the client is in adopting coping or defense measurement. Encourage systemic desensitization. Neurotic disorders is a less severe form of psychiatric disorder where patients show either excessive or prolonged emotional reaction to any given stress. These disorders are not caused by organic disease of the brain and, however severe, does not involve hallucination and delusion. They are classified under F4 in ICD-10. Phobia anxiety disorder. Anxiety is normal phenomena which is characterized by a state of apprehension or uneasiness arising out of anticipation of danger. Normal anxiety becomes pathological when it causes significant subject distress and impairment of functioning of the individual. Anxiety disorders are abnormal state in which the most striking features are mental and physical symptoms of anxiety which are not caused by organic brain diseases or any other psychiatric disorder. A phobia is an unreasonable fear of a specific object, activity, or situation. This irrational fear is characterized by various features. It is disproportionate to the circumstance that precipitated it. It cannot be detailed with the reasoning or controlled through the willpower. The individual avoid the feared object or situation. In phobic anxiety disorder, the individual experience intermittent anxiety which arises in particular circumstances, that is, in response to the phobic object or situation. Types of phobia: simple phobia, social phobia, agoraphobia. Simple phobia means that it is an irrational fear of a specific subject or stimuli. Simple phobia are common in childhood. By early teenage, most of these fears are lost, but a few persist till adult life. Sometimes they may reappear after a symptom free period. Exposure to the phobic object often result in panic attacks. Signs and symptoms of specific phobia: irrational and persistent fear of object or situation, immediate anxiety or on contact with the feared object or situation, loss of control. Social phobia: it is an irrational fear of performing activities in the presence of other people or interacting with others. The patient is afraid of his own action being viewed by others critically, resulting in embarrassment or humiliation. Signs and symptoms of social phobias are hyperventilation, sweating, palpitation, confusion, urinary urgency, muscle tension, anticipatory anxiety, clammy hands, cold, fear or embarrassment of ridicule. Anticipatory anxiety occurs well in advance of a particular situation, such as a public speech or social event. This leads to thought of dread leading up to the event. The added anxiety results in actual or perceived failure in the situation, leading to embarrassment and further anxiety. This pattern set up as vicious cycles of persistent discomfort that can be incapacitating. Many people who have social phobia are underachiever because of test anxiety, poor job performance, poor communication skill. They may have few or no friends, a support system, decreased support system. Agoraphobia. Agoraphobia is characterized by irrational fear of being in place away from familiar situation of awe in crowded or situation that the patient cannot leave easily. As an agoraphobia increases in severity, there is a gradual restriction in normal day-to-day activities. The activity may become so severely restricted that the people become self-imprisoned at home. Signs and symptoms of agoraphobia are overriding fear of open or public spaces, deep concern that help might not be available in such place, avoidance of public places, and confident to home. When accompanied by the panic disorder, fear that having panic attack in public will leads to embarrassment or inability to escape. Theology, psychodynamic theory. According to this theory, anxiety is usually delayed with repression. When repression fails to function adequately, other secondary defense mechanisms of ego comes into action. In phobia, this secondary defense mechanism is displacement. By displacement, anxiety is transferred from a really dangerous or frightening object to a neutral object. These two objects are connected by symbolic association. The neutral object is chosen unconsciously in the one that can be easily avoided in day-to-day activities. In contrast to frightened learning theory, according to classical condition, a stressful stimulus produces an unconditional response fear when the stressful stimulus is repeatedly paired with a harmless object. Eventually, the harmless object alone produces the fear, which is now a conditioned response. If the person avoid the harmless object to avoid fear, the fear become a phobia. Cognitive theory. Cognitive theory, anxiety is produced of factually cognition or anxiety inducing self instruction. Cognitive theorists believe that some individuals engage in negative and irrational thinking that produce anxiety reactions. The individual began to seek out avoidance behavior to prevent the anxiety reaction and phobias result. Causes. The phobias are more common in women with an onset of in late second decades or early third decade. Onset is sudden without any causes. The course is usually chronic. Sometimes phobias are spontaneous remittent. Diagnosis. No specific diagnostic test. Diagnosis confirmed if ICD-10 criteria met. History of anxiety when exposed to or anticipating specific entity of situation. Treatment. Pharmacotherapy include benzodiazepam, antidepressants. Some antidepressants are, for example, imipramine, sertraline. Then behavior therapy, desensitization therapy to gradually reintroduce the feared situation while coaching the patient of relaxation technique. Role playing is guided imaginary to allow the patient to rehearse way to relax while confronting a feared object or situation. Assertive training to help the patient become assertive in her interpersonal interaction. Modeling behavior, that means patient observes someone modeling or demonstrating appropriate behavior when confronted with the feared situation. A cognitive behavioral technique called negative thought stopping to reduce the frequency and duration of disturbing thoughts by interrupting them and substituting competing thoughts. Teach the patient to recognize negative thoughts. Involve using an intense distracting stimulus to stop the thoughts. With practice, allow patient to control thoughts without using distracting stimulus. Psychotherapy. Psychotherapy means it is supportive. Psychotherapy is helpful to adjunct to behavior therapy and to drug therapy. What are the other nursing management of this condition? Assessment include firstly nursing assessment. Assessment parameters focus on physical symptoms, precipitating factors, avoidance behavior associated with the phobia, impact of anxiety or physical functioning, normal coping ability, thought content, and social support system. History and medical examination.